Dr. Manish again. So we have already learned the various phases of fracture healing and how do they proceed in a rhythmic manner. We need to understand what are the various factors that may affect the different stages of fracture healing, especially pertaining to the indirect bone repair. Also, we would like to know if we can really do something to exploit the knowledge which we gain from the understanding of the variables that affect the fracture healing and the types of fracture healing and the way the fracture healing progresses, the various factors which mediate them, the cellular elements that mediate them. If we can combine that knowledge to exploit to the best of the outcome which we can get for the patient. So directly going to the variables or the factors that affect the fracture healing, they start from the injury pattern itself when a bone gets injured. So these injury variables, patient variables, then the tissue or the bone tissue, type of bone, quality of bone, the type of soft tissues and the quality of soft tissues, and very importantly the treatment variable, because most of the time the patient with a fracture would land up in the emergency and will definitely show to an orthopedic surgeon. Then he will be given some or the other treatment. Now that treatment can alter the process of fracture healing itself. Now first we discuss the injury variables. The most common injury pattern that affects the outcome of the fracture, and the outcome which we discussed was the immediate outcome of a fracture is fracture repair itself. Now the process of the fracture repair will get altered with an open injury. How? See, we discussed the first stage was hematoma formation. In an open injury, the hematoma will be lost. Then the second stage was the inflammation. Inflammation is difficult to come by directly just because the pertinent cellular elements which were supposed to be present in that local milieu will be lost again. The periosteum is damaged, the soft tissues are badly contused, there is bone loss, the bone may be lying at the site of injury itself, would have been lost there. There is complete disruption of the blood supply as of now which can be seen. See, nearly half of the circumference of the bone in the lower part and nearly 2/3 of the bone circumference in the upper part seems to be naked. It may not have very good blood supply. And above all, open injuries are marred with the presence of and the risk of infection. That itself has a separate bearing, negative bearing in fact, on the healing process of the fracture. The other thing is high velocity injury or the severity of injury. High velocity injury is more or less an open injury in which the hematoma is not lost. How does it matter? See, although hematoma is there, it will get organized also. So the stage 1 of fracture healing will start. There will be kick-starting of the process. But we should realize that the loss of the blood in that region or accumulation of the blood in that region will cause increased pressure. That causes reduced capillary flow and the necrosis of the bone ends. Even the high velocity of injury would impart a lot of energy to that region, localized to that region. That will cause increased comminution. The more the fragments are comminuted, they lose their vascularity even faster. Also, the soft tissues will get too much energy transfer and even they will suffer so much damage that the inflammatory process will be expanded and it will be expansive in nature, exceeding the boundaries of the bone. So a lot of the inflammatory mediators will get diluted into managing the soft tissue element also. There is a lot of associated displacement and comminution, which is discussed that the comminution leads to presence of necrotic small bone fragments, and the relative ischemia comes from the pressure of the soft tissue. Because high velocity injury definitely leads to disruption of vascularity, whether it is of bone or the surrounding soft tissues. It causes poor migration of mesenchymal cells that seem to come to that area through the blood vessels, or they may diffuse from the surrounding soft tissues. Now, the soft tissues also have got disrupted or damaged, so the mesenchymal cell availability will also be reduced. The other variable is presence of a segmental fracture. A segmental fracture introduces two sites where bone repair has to be done. Although it seems to be a segmental fracture, actually the central fragment was in three different pieces. So there were 5 different places where the fracture union had to occur. And actually it was nightmare operating on this patient with polytrauma. There was abdominal injury also. And such fractures impose a lot of demand on the body for healing, and that healing process may get derailed or slowed down, marred, hampered or altered at some or the other place, and may lead to poor outcome in the form of delayed union or non-union. And the next variable is infection. Presence of infection per se should not hamper the process of fracture healing. But infection may introduce components like vasculitis. And it has been found that some of the gram-negative infections, especially the pseudomonal and the coliforms, they produce cytotoxins that inhibit the osteoblasts. Now, these two factors may hamper or alter the process of fracture healing, but they do not totally disrupt it. The second thing is that whenever there is infection, body tries to control that infection also, and lot of body's response in the form of cytokines, inflammatory mediators, get diverted towards managing and walling off that infection. This is the reason why body pays less attention to fracture healing or the process of repair of the fractured bones, rather than it gets diverts its resources into managing the infection itself. The energy consumption also increases. This is the main reason why in the presence of infection we see a delay in fracture healing. If the fracture is very near to the bone joints, then there is an additional demand of increasing the stability of the construct or the osteosynthesis. This entails higher soft tissue dissection, so it leads to loss of vascularity even more. One. Number two, the fracture by itself, because it is imparting energy to the cancellous bone, which is a softer version of the bone, that gets impacted, and there will be free floating fragments of the cancellous bone which may not have still separated from the parent bone. So a surgeon may not realize that there is actually a avascular part of the bone present, which we think during surgery that it is a part of original bone and is completely vascular. So there are higher chances of complications, fracture subsidence, and ultimately implant failure, joint stiffness, and development of arthritis in these periarticular fractures. So it is considered a separate injury variable. Soft tissues can get interposed whenever there are two separate fragments of the bone. Muscles, nerves, neurovascular structures, tendons, ligaments, anything can come in between, and they cause total disruption of the continuity in the callus or the fracture hematoma itself. Now, because the continuity is disrupted, so the process will not complete in a single go. The process will be occurring, but at two different places. In between, there is no continuity in that process, so the fracture may not heal, and there would be non-union. Ultimately, it may lead to pseudoarthrosis also. To manage such fractures, we need to alter our management approach. We cannot manage them conservatively. So plaster treatment is usually, it is not successful. Even close reduction may not be possible. So you have to go for open reduction in such cases. Now, because of the corona, these x-rays are very common. This is the x-ray of a 5-year-old kid who suffered from fracture supracondylar, and you can see after 4 years when he presented back, there was a lot of bone formation. We already discussed that in infants and children there is a very high potential of fracture healing because they contain thick periosteum that contains lots of pluripotential cells, and also the process of remodeling is very fast in them because in infants they have higher amount of estrogen and progesterone which is coming from the mother, and in children there is lesser amount of testosterone, so there is relative estrogen excess in them, so that also causes faster remodeling in them. So, younger patients have very high healing potential, we should remember. So, the delaying surgery may be adequate for adults, maybe up to 7 days or 5 days, because if there is some medical comorbidity or the local milieu, for example, in a distal tibia fracture or tibial pylon fracture or a calcaneum fracture, we tend to delay the surgery by 5 to 7 days till the time of acute reactive inflammation subsides. But in children, it may be harmful because their bones are very fast to unite and also they have faster remodeling potential. So by the time you would go for surgery, you would see that there is a lot of proliferant callus formation and you are not able to see anything in reality. The nutrition plays a very important part after a fracture occurs because fracture imposes a lot of metabolic demand on our body. So we need to have good amount of mineral and hormonal balance to manage that metabolic demand, especially the calcium, phosphate, boron, zinc, magnesium, vitamin K, vitamin D, vitamin C, and A, C, D, and K. They should be in adequate amount for the fracture healing to be proceeding in the normal manner, speed, and the particular steps which we had already discussed. There are factors that alter them. For example, if a patient has polytrauma or he is an alcoholic, then most of the time these fat soluble vitamins are lacking in him. Smoking is a direct inhibitor to the osteoblasts, so the fracture healing will not be very. It is considered that one should ask the patient to stop smoking as soon as he has fracture, otherwise the outcome is bad. The patient with multiple injuries or a polytrauma patient consumes lots of these vitamins and nutrition factors to manage the injuries all over the body. That also causes a relative deficiency at the fracture site. Medicines like NSAIDs, we discussed them, they inhibit COX-2 enzymes, so they will inhibit the stage 1.2, I would say the state of inflammation. Then the anticoagulants will prevent organization of the hematoma, which we have discussed that the hematoma, if doesn't get organized, then the cells will not get a substrate where they can home in and then differentiate and form bone or the tissues. Cytotoxic drugs obviously will prevent any cellular proliferation and further laying down of the bone. Hormonal influence. The hormonal balance has to be very good in a patient. If there is excess of hormones, for example, in patients who are taking corticosteroids for some or the other reason, patients with pulmonary disorders, renal disorders, they often are on steroids. The fracture healing will be delayed because the steroids directly inhibit inflammatory phase. They are strong anti-inflammatory drugs. They also have negative influence on the metabolic components of the cells. For example, the osteoblasts get inhibited, osteoclasts may not get inhibited. The other thing is that some patients are deliberately taking steroids, for example, the weightlifters, the bodybuilders, in them also. One should be very cautious and one should be very pertinent in particular in telling them that you have to stop using those steroids unless and until the bone has fully remodeled. We know that the remodeling time is nearly 1 year, but it may persist for life. That is a separate issue, but it should be stopped for at least 1 year. Anabolic hormones are good if suppose the fracture healing is not progressing well. Then if the patient is diabetic, you can switch him to insulin. It helps in fracture healing and repair. Patient is hypothyroid, give him thyroid hormone and thyroid hormone supplements. They improve fracture healing, bone healing, even the osteoporosis. Anabolic steroids per se are not indicated to improve fracture healing, but it has been seen that the patients who need intensive care, the patients particularly of polytrauma, may do well if they are given anabolic steroids. Type of bone has a direct bearing. We discussed that the cancellous bone contains lots of cells and it has very good vascularity, so it is fast to heal. Whereas a bone which has been damaged either by radiation, that causes radiation necrosis, or the bone is pathologic by itself. For example, the phagetic bone, the bone which has fibrous dysplasia. Fibrous dysplasia causes geographic bone defect in which the trabeculae are in the form of totally unorganized, small, segregated, discrete patterns. We call them Chinese letter appearance. This area of the bone will not reform a good healthy adult bone, and you have to completely replace that bone by the bone graft. Pseudoarthrosis is again a similar condition, for example congenital pseudoarthrosis of tibia, where the area in which there is pseudoarthrosis does not contain any viable amount of bone or the bone forming tissue. So no matter how you keep on grafting the area, the bone doesn't heal. You have to use alternative methods. Treatment variables we discussed. Each of these modalities, which have been now famously used by orthopedic surgeons using the metallurgy in orthopedics, alters the type of fracture healing or the fracture repair process. But we will discuss the two most extremes of it. One is the plate fixation of the bone. This causes rigid fixation of the fracture, compressing it if you are using it in compression mode. Then what happens is, although the gap is reduced and you see an anatomical sort of reduction, but the cyclic loading is completely eliminated. So there will not be external callus formation. So now we remember that external callus was a requirement in indirect bone repair. If the external callus is not present, then the bone can either go into creeping substitution or primary bone repair. Creeping substitution is not possible here because there is cortical bone. Creeping substitution occurs in cancellous bone. So the bone has to heal by direct repair. We knew that there are only two methods in direct bone repair. One was the Haversian remodeling, we also call it osteonal remodeling, or the cutting cone mechanism. It occurs only if the gap is less than 400 micrometers. But if the gap is greater than 400 micrometers, then gap healing will occur. So both of these things will require good amount of vascularity. If the vascularity is not there, then this bone will not heal. So amount of non-union or the incidence of non-union with plate fixation had been high because people have been devascularizing the bone, removing the periosteum, and the blood supply is often lost. To the extent that the primary bone healing or the gap healing cannot occur. The second fixation method is the intermedullary nailing. Now in the intermedullary nailing, we see that all the phases of fracture healing will be seen in direct bone repair. All the phases, even the intermedullary callus, the external callus, the primary bone callus, subperiosteal callus, all of these things are seen in intermedullary nailing, and there is prevalence of the callus. This is the particular patient where the surgeon would flaunt his X-ray and say, look, you have got so much of the beautiful bone formed around your fracture, and now the fracture has healed. Why this external callus forms in nailing and why it doesn't form in plating? The primary reason is the stability which is achieved. In nailing we achieve relative stability, but in plating we achieve absolute stability. So when there is no stress or strain, it is absolutely a rigid fixation, then there will not be any extrinsic tissue formation. For a tissue to form or for a callus to form, it is often said that it needs the two ends moving in a particular manner to produce the callus. So if there is no mobility, no callus will be formed, and the bone will rely only on primary bone repair. The fracture will rely on primary bone repair, whereas relative stability provided by nail produces some micromotion at the fracture site, leading to formation of indirect bone repair through callus. Now, what are the methods which can be used to enhance bone healing if it is not following the rate and the extent which we desired? There are biological methods and mechanical methods which we can use to produce a very good fracture healing pattern if the fracture healing has derailed. What are the biological methods we can use? The most common used is the bone grafting. Before we understand bone grafting, we should know three terms: osteoinduction, osteoconduction, and osteogenesis. Osteoinduction. Induction is to induce things. Induce means kickstart the process. This process induces the pluripotent stem cells or the primitive mesenchymal cells which are present at the 5 locations we discussed in the previous lecture to differentiate into osteoblasts. Osteoconduction. You have to conduct something, then you should be a part of it. So if you have to conduct bone, then it needs to form bone. That means osteoconduction is formation of bone. Osteogenesis is again generation of bone or regeneration of the bone by bone forming cells. Now how is it different from osteoconduction? Osteoinduction and conduction both used cells which were extrinsic to the tissue. They were the pluripotential cells or the mesenchymal stem cells that transformed into bone forming elements. But in osteogenesis, this is the term used for formation of bone by the bone forming cells themselves. They are not changing their form. The osteoblast, if they form bone, it is osteogenesis. Mesenchymal stem cells, if they change into osteoblast by induction and then that osteoblast lays down bone, is osteoconduction. So bone grafting has been classically indicated in filling the defects and cavities which may be left behind because of, say, open trauma, or if the fracture is not completely reducible, or in places where there is extensive bone loss due to necrosis or combination. They can be also used for fusion, but those are other indications of the bone graft. Particularly for fracture, it is to fill the defects and the cavities, and an additional indication is management of delayed union and non-unions. Bone grafting has been prevalent even before we learned how to use metal for our osteosynthesis. They have been used rampantly for even curing infection. We remember of techniques called Pepineo technique for open fracture management, where the bone graft was done without any fixation method. Only the plaster was applied and bone grafting of the fracture ends was done to improve or facilitate the bone healing. The different types of grafts which can be taken are cancellous, cortical or corticocancellous, depending on the predominant amount of or predominant type of bone which is present in the graft. Cancellous grafts are very good at osteoconduction and induction, whereas cortical grafts provide immediate strength. Cortical grafts can be again divided into whether they are vascularized or they are non-vascularized. Vascularized means you take that cortical graft, for example fibula, which is a typical cortical graft, along with its vascular pedicle. Why you need a vascularized cortical graft? Cortical grafts are slow to incorporate. It is a thick and strong bone, slow to resorb, whereas cancellous bone already has intrinsic good amount of vascularity and cellular elements. It gets resorbed very fast, and also the new bone is laid down on it very fast. But the cortical bone is slow to resorb and also very slow to reform. But the cortical bones provide immediate strength to the site where it has been used. So depending on the indication, we can choose our graft. Most commonly we need both strength as well as osteoconduction and induction. So we tend to use graft which has both cortical as well as cancellous components, usually like tricortical iliac grafts. Overall, if I say, the use of graft has dwindled over a period of time. Nowadays, there are very few indications in which a primary bone grafting is required. It is more or less nowadays indicated for delayed unions and non-union management. There are lots of techniques which have been described, but the most common technique which is used nowadays is for osteoinduction and improvement of fracture healing by way of impacting cancellous chips of bone there. This is a typical fibula. It can be cut in the form of cylinders or pegs for different indications. But usually in fracture management and the management of delayed and non-unions, we take use of cancellous bone and impact it at the site. Very often we see that the patient's own bone falls short of filling the defects and the cavities which have been present because of the bone necrosis, combination, or the absence of bone because the bone has been lost during the injury itself. Other times, because of the infection, the bone may get resorbed, and during debridement a lot of bone gets lost. In these situations, we need extra bone which cannot be really supplied by digging into the patient itself. So in these situations, allografts come handy there are two types of allografts which have been the way they have been prepared. One is the frozen form, where the immunogenicity of the graft is retained without any change in its biomechanical properties. The other one is freeze-dried graft, which removes a lot of water and the immunogenic cells like lymphocytes, macrophages. This reduces its immunogenicity, but there is some alteration in the mechanical strength also, because we know bone is a hydrated tissue. If you remove water from it, it loses some of its effect. If we are required to use bone in situations where we want bone to be formed again, then we would prefer freeze-dried cancellous graft. But in situations where we need primary bone stability to be immediately restored, for example in arthroplasties and tumor surgeries where a lot of bone is needed, but we need immediate strength also to be regained, then in those situations we will use frozen cortical grafts. Because India is a developing country, we don't have bone banking facilities so rampantly distributed all over the country. In these situations, we cannot obtain allograft whenever and whatever amount we need. In such situations, we can use demineralized bone matrix. Here the bone is cleaned of its mineral component by acidification process using 0.5% hydrochloric acid, and the matrix which remains is quite rich in the protein component and also the cellular component, plus the bone-genic or the osteogenic factors. Now this can be supplied just in the form of putties, powders or even paste, but it has been seen that if you add some additives to these demineralized bone matrix, it becomes easy to handle. As soon as it is placed at the site, it hardens and provides the necessary stability. You can also form it in the desired shape, because it is a paste type of material which can be formed in the desired shape. It can be pushed into these spaces, and hence it helps in regeneration of the bone. If we need only the osteoinductive and the osteogenic potential of our graft, then it is better to use bone marrow transplant or bone marrow. Why we call it transplant? Because it is taken from some other site and transposed to some other at a different place. So it is a transplant, even if it is done in the same person. It has got mesenchymal cells that are usually present with a density of 1 in 1 lakh. So one should remember that if you keep on aspirating bone marrow from just one side, which is a very common error, then it would suck only the blood and will not get mesenchymal stem cells. The cells don't keep on forming. They are present at the surface of the trabeculae and the bone marrow elements. If you have sucked a part of it, then change the direction of the needle, go a bit deep further, and then again suck around 1 ml of it. The second error is people often think that just injecting 5 to 10 ml of bone marrow will suffice and help the treatment. No, it is not. You need at least 30 to 50 ml of bone marrow to be injected at that site where you need it. Usually it is done for delayed unions and non-unions. And the volume should be sufficient to provide as many mesenchymal stem cells as we desire to form the bone. Just 5 to 10 ml will not supply that much amount of mesenchymal cells. The approach, another method of improving bone healing, actually it is not just a healing process, it is a process in which the bone defects are filled, and this is commonly done with the Russian technique of Elizarov, where you transport a segment of bone altogether to fill that defect by doing a corticotomy. At the corticotomy site, you have to maintain latency of 7 to 14 days depending on the age and how well you have done the corticotomy. If the corticotomy is done very well in the best manner, then the latency of just 5 days may also suffice. But if it is done a through and through osteotomy, then it is better to wait for 2 weeks in such patients. Sometimes even the demineralized bone matrix may not be available because of cost constraints. Then we have bone graft substitutes available. Now these bone graft substitutes are more or less ceramic elements. Now this is not the pottery ceramic. Ceramic means they are crystalline structures derived from either calcium, silicon or aluminium, and they are produced by high heat or high temperature sintering process that fuses the crystalline structure into either blocks or granules. Now they are quite brittle because they contain only the mineral element. There is no protein or the collagen element in them. They have got very high compressive strength, but they don't have any tensile strength. They are highly brittle. The other problem is that if the process is really good to produce it, I would say if the process is really good, then the resorptive capacity and the remodeling capacity both are reduced. If there is some lacunae in the process, it may lead to some amorphous structure present there, and those amorphous structures are easy to resolve. Now, the major synthetic ceramics are derived from calcium. The most common one used is calcium phosphate in the form of beta tricalcium phosphate. There is alpha form also. Alpha form is not as crystalline and it resolves very fast. Beta tricalcium phosphate is the most common crystalline structure used because it lasts in the bone at the site where it has been implanted for a very long time. That is also a drawback of it. Sometimes you may see calcium beta TCP lying at the fracture site even after 10 years. But this is the most common osteo conductive method which is used apart from bone grafting. The newer method is supplying the beta tricalcium phosphate in the form of cement. Using blocks or granules or even the powder form is a bit cumbersome. The blocks may not fill the real defect. You have to crush them. The granules also may not fill into the bone gaps which are left there. So it is better to inject a paste form of the same calcium phosphate that will insinuate itself into all the creeps and the defects which are present at the site. BMP has been called a wonder molecule. Since the time it was discovered and described, it was considered as a magical cure for non-union and delayed union and even difficult surgeries like multi-level fusion in the spine and high-grade osteospondylolisthesis. But it was found of late like the interest has reduced in bone morphogenic protein. Reason is the bone that forms at the site using bone morphogenic protein is still immature, number one, and it is uncontrollable. A lot of instances have been recorded where BMP was used and it led to spinal or the neural compression. At the non-union site, it has been recommended, but the problem is of carriers. Presently, nearly more than 20 types of the bone morphogenic proteins have been described. This is a family of TGF-beta superfamily. BMPs are not specific to bone. They are also as important for cardiac tissue, for the neural tissue, and also pancreas. Only the BMP1 belongs to matrix metalloproteinase category. The rest all others are from TGF-beta superfamily. Apart from BMP3, rest all of them stimulate bone formation. Clinically and commercially, BMP2 in the form of infuse, RHBMP2 or recombinant human form, or BMP7 in the form of OP1 is available. They help in multiple stages of osteoblast and osteocyte formation right from the mesenchymal stem cell stage. That is how they induce bone formation. They cannot form bone by themselves. They induce the cells to form bone. So it is a purely osteoinductive method of bone formation. The carriers have lately been modified to provide a requisite amount and requisite concentration of the BMP in a limited amount so that extra bone doesn't form, which we discussed was a drawback of using them. Although it was considered magical, but still not many people are using it for curing non-union, and the results have also not been very consistent with it. The alternative methods like bone grafting and the conventional methods of improving stability have been much more better. Prostacyclins are just a research molecule. They are added here only to know that they can also improve bone formation. Platelets, I call them, these are the magical cell and the magical factors that can not just improve bone healing, they can enhance bone healing. They may be the future for treating non-unions and delayed unions. Already use of platelet-rich plasma is going on for delayed unions. For non-unions, it has not been directly approved, but PDGF, one of the most important factors of platelets, has been approved for ankle fusion and as an extended indication for management of pseudoarthrosis. So we have discussed all the biological methods in detail. Now we would like to discuss the mechanical methods and how the mechanobiology alters the fracture healing and how we can use mechanobiology to our benefit. Before understanding it, we should remember that there are stress and strain patterns. We know that the Powell with this diagram showed that there should not be excessive strain, neither there should be excessive stress on the fracture elements. Otherwise, the fracture healing doesn't progress in the desired manner. Then we should also know that the bone is an electrical material. It has got three types of potentials. One is the streaming potential. Streaming potentials are generated whenever a liquid is forced through a porous material. It leads to alternative compression and expansion of the fluid, generating streaming potentials. Piezoelectric potential is the property of any crystalline structure when it is subjected to deformation or a stress or a strain. The bioelectric steady state potential again reminds me of the fact that negative is not bad. Wherever there is growth occurring, active growth occurring or active metabolism, that place is usually electronegative, whereas the place which is metabolically silent and not much growth is happening or not much activity is there, it is electropositive. These are the most common electrical methods described, but I have not seen anybody using them. One should just remember that there are three most common methods of electrically inducing or supporting or enhancing bone healing. DCE or the direct current is an invasive method in which the electrodes are directly implanted into the site where you want more bone healing, whether it is a fresh fracture or it is a delayed union or non-union. Yes, it is also used for fresh fractures, but it is an invasive method, so not very popular. Pulse electromagnetic field force and the capacitive coupling, both are non-invasive methods, but they require long duration and long cycles for really producing any effect. Although very inquisitive, but there are not many indications for use of electric currents for improving the bone healing. The only two indications which I find I have seen being used are in the smokers, where it has been advocated in European countries, and those patients are subjected to PEMF very commonly. The other is a multiple level spinal fusion, where the electrodes can be placed at the fusion levels, and there the patients are provided with the electricity generator, which is kept for around 3 to 6 weeks, and it leads to improvement in fusion at the sites, because multi-level fusions are at high risk of failure. So this method may definitely help them. We have already discussed the mechanobiology and the impact of stress and strain on the bone formation. In a nutshell, if we want to remember again, if there is low level of mechanical stimulation, it leads to osteogenesis. If there is excessive compressive stress, it leads to chondrogenesis, no bone formed. If it is intermittent strain, we discussed like the shear strain, there will only be fibrogenesis, or it may halt at granulation tissue level only. If there is cyclic tensile strain, it will accelerate endochondral ossification. But where do we see this? We see this in Elizarov. Whenever we do distraction, it causes distraction osteogenesis. Elizarov called this distraction histogenesis because it leads to tissue formation, which later mineralizes into bone. Now that is the only situation where you would see practically this cyclic tensile strain on the tissue, and there you see endochondral ossification. If you change that strain into stress, it will impair endochondral ossification. Where would you see that? Now, this is seen if you mobilize the fracture very early. It will fail at the soft callus stage itself. and there will be no hard callus formation. But we can exploit this for our own benefit. We can provide this cyclic mechanical loading by mechanical devices and produce controlled micromotion at the fracture that will improve fracture repair. Or otherwise, we can do that using functional cast bracing, as was exploited by Sarmiento. What it does, it reduces venous stasis because the limb is mobile. There is increased arterial blood flow, there is increased interstitial fluid which returns to circulation, so that there is no dilution of the factors at the fracture site itself. There is increased nitric oxide and prostacyclin. We discussed prostacyclins enhance fracture healing, although we are not using them practically. There is also a proposal that the plasminogen activator inhibitor is reduced. It improves the hematoma organization. This is the most classical example of exploiting mechanobiology to our own benefit, and it was propagated by Sarmiento, described in detail about management of humerus fractures and the tibial fractures using functional cast brace. What it does is, if you support the limb in a functional brace which compresses and holds the limb steady, then it forms a cylinder where the elements within that cylinder will not be subjected to strain. They will be subjected to cyclic loading because the joints around are mobile and the muscles will be compressing the fracture site. Now this is a very good method of managing such fractures, especially the humeral shaft fractures and the tibial shaft fractures. A lot of people have been using it, and it is a very successful method that produces bone and callus very fast. The amount and the volume of callus produced is also very large. This is the last method which we will discuss, and which is used of ultrasonic waves, especially the low intensity pulse ultrasound. If you use high intensity wave, they produce heating effect, but the low intensity one reduce inflammation and also enhance and stimulate differentiation of cells. That means they are also sort of osteoinductive. The cell proliferation, protein synthesis, and improvement in calcium levels stimulate osteogenesis and angiogenesis. Now the vessels which really come at that site also provide not only just the oxygen, but they also provide the nutrient elements, the minerals, the vitamins, and very importantly the mesenchymal stem cells, which we had discussed that vascular vessels are also a very important source of pluripotential stem cells. Ultrasound has been approved for management of fresh fractures, especially the smokers, and it has been found useful for infected and non-infected non-union both. The extracorporeal shockwave lithotripsy also has similar effects, just like the ultrasound. So we have already seen that fracture is a natural, unique and complex process that progresses in a particular rhythm. Although we have learnt it in the form of different steps, but in reality it is a continuous process, and all the steps which we have delineated have their own dependencies that can be exploited using biological or mechanical methods to the benefit of the patient primarily. But one should always remember and understand that these methods of enhancing fracture healing are not at all a substitute for good primary management, which should be the priority of a surgeon. Thank you.